Awesome. So the plan for today is we're gonna go over action potential, which is all gonna be all on the board. We'll go over ABGs. I teach a tic-tac-toe method for arterial blood gases. And just whatever comes up in between for whatever. This is something I added to the syllabus that wasn't in the last two AMT classes. Because I think it is something that's important for you all to know. And then we got to do lunch, but I'll probably do it early lunch because I got to run some start some taking pictures and stuff for tonight or for tomorrow night for my EKG class. So it's a whole new, I don't know, they gave me a whole new curriculum of books. I got to learn that tonight. And then we're going to do some group testing. Maybe if we have time, we'll do some scenario stuff. We'll see. I could not find a divider to go into the jump bag thing. So we're going to have to either get some pouches or something to go in there. I don't know. We'll keep working on that. How's everybody doing?
Pretty quiet for what, yeah.
Pretty quiet. Anybody had any good calls in the last 2 days?
Well, I guess not really. I went and called Florida and just I feel like the hospital. We were
Is that
trying,
the shooting, the 14-year-old?
that was the day after,
Oh,
but, we were transporting a patient. I had to call ALS. So I was driving the QRV behind the ambulance and his car like swung behind me on 521 and followed me all the way there. And we get to the hospital and he swings
did it have
around.
blue lights and sirens? Okay. Yeah.
He swings around me and pulls in the ambulance bay like the wrong way.
Yeah.
And my driver who was in the ambulance, he went to roll down the window and say, "Hey, you can't park here." And the door swings open and the dude just falls out unconscious on the ground and just started pooling blood underneath him. He had been shot and drove himself. He
Wow.
followed us to the hospital.
That's a little smart move. Good thing you weren't going to like suffer dialysis or like going out the covenant place. Wow.
Yeah,
So
but
did
whoever
he
shot
survive?
him, they said it's gonna be okay, but he was really bad. That whole shift, we had 3 different shootings.
There's been a lot of shootings recently. 14 they had, it wasn't my call, I just saw it, pop up. A car in a ditch submerged underwater. Was that your ship?
Day before.
Yeah.
That was day before yesterday.
I went to an old lady who 70-year-old who fell down about 8 steps last night, hit her head on the drywall, literally hole in the drywall. Snore respiration.
It's like, I don't know what the fault.
Just lucky. Like, gee, we did spinal movement restriction and took her to Timmy. She, was other than asking if she was still in West Virginia, she was with it. And so anyway, she had to go to the donut and tree filter. We couldn't find any other problems with it. We didn't have any, other fractures or anything like that. Some
That's good.
femurs were good.
We had,
People were good.
I had a guy, 2 days ago, much ago, they came across right now, one, dispatch said you're going to, like 74-year-old male patient sweating. No,
Hey,
well,
hey, man.
I'm like, what is it wrong with you?
What? Sweating could be a lot of things.
Yeah, well, I mean, they say he's conscious, he's just sweating. I said, okay, well, he's probably just
Sounds
dehydrated.
cardiac to me.
Okay, I get there, and the old lady in the front row is like, "Can you please hurry?" I said, "Yes, no problem, we're coming." And we get there, and he's like in the prone position, laid down with no pants on, with a catheter in, and he's just shaking.
Oh
I
my
said,
goodness.
"Oh, hold up." See, I touched
Wait a
him.
minute, something right.
Hey, he's burning up. Man's got 130 years.
Septic is
He's septic as can be. He was shaking. His SpO2 was 81. Was like 120. It was,
That's wild.
yeah. But hey, we got down, got everything back up, put the positivity up in that land, and he was good to go.
The Bashara lady, we of course we did everything. She's diabetic, checked BDL like 200. It said normal for her. Did a stroke exam, nothing on stroke exam. Did an EKG 12 lead, nothing there. Other than the fall and hitting her head and phone respirations, which the best case scenario she's got a concussion, right? Worst case scenario she's got a brain bleed. Do you think I ALS out that right or BLS out right? BLS right, baby. So I think that's the way it should be. There was no interventions for ALS. We let the cardiac monitor in place. Stick around.
As soon as we throw 12 lead on, oh, well.
No,
Not
we
even
need to
less-
change that.
Yeah.
Yeah, it needs to change. You don't have to have it. I don't know how to pull it back up. Is it this button? Nope, this button. HelloSmart.com. But if you do, it will cast it to your screen there, and then you can, but I'm also recording to Zoom, so I will post the Zoom video. Yeah, I'll let the basic grab that thing in. You know why? Because that's a good course you can learn from and do your assessment. And sure enough, as soon as we walked in the door, the fire department said, she's waking up. And my EMT partner goes, you want me to check a PGL? I said, no, I want to do a primary assessment. So anyway, we talked about it on the ride in. You got done with this? We talked about it after the call. And I drew out the whole thing, like we did here with the scene and XABC or ABC or APTU, XABC, sample, OPQRST, little person. That's all primary assessment. So as we're getting back there, so let's talk about this. First thing, when I walked out to the truck, I had it in my GPS address. And she's driving, so when I sat down, she's got it on her GPS. She goes, Yates. I said, that's funny, we'll go pull it up. So we take off, and she's driving like this, code 3. I said, what are you doing? I said, put the phone down. I am your navigator. I said, put 2 hands on the steering wheel, please. Don't kill me. Because we got toned out. They said it was a 7-year-old who was unconscious or whatever.
When I was a driver, I used to have my partner be my navigator, and there was one person who would always be my navigator, and we would be driving, and he's like, where you going? I was like, what do you mean, where am I going? I was supposed to be telling him, oh, you took that turn like 2 blocks ago.
They should be in this curriculum.
No, my driver got lost going to the hospital, or better yet, sitting at base. She put in her GPS, the base station, I'm going, you can see it.
Yeah.
Literally,
I was like, I'll be your navigator. I'll tell you where to go. Just please focus on the road.
look at the hospital and then make a left-hand turn.
So we talked about that. And then on the way, when we were in the truck, on the way done with the call, I said, let's talk about the difference between a primary assessment and a secondary assessment. So I drew it all out. And I said, okay, secondary assessment is vital signs. What are the vital signs? And when she got to BGL, I said, and that's the problem. You were trying to do a secondary assessment before we started our primary assessment. She goes, well, I'm just doing it the way the military medics do it. And the problem with the military medics is they don't know what they're doing, so they don't follow systematic medics. I said, don't do that. Do what the civilians do. We all have 30 years of experience each. Okay. Interesting stuff. Let's do action potential. Does anyone know what action potential is? You might know. No. This is what's happening at the cellular level. And I think if you understand what's going on at the cellular level and how the cell functions, then maybe this will be a good building block for everything else. So action potential is really what's going on at the cellular level. So this is the cell, and this is not what a cell looks like. But in my 5-year-old brain, this is how it makes sense of very complicated things. This is the cell, and this is the cell membrane. When you think of cell membrane, I want you to think of, you know what a cation is? You know what ions are, right? Cations. So a cation is a positive ion. And I don't know the best way to remember that, but the ion you need to know that keeps the cell membrane together is calcium. And it has 2 pluses. That's how positive that one. So calcium plays an important role in keeping the cell membrane together, right? So it keeps that cell membrane together. And it also plays an important role in the movement of electricity across the membrane. That's the membrane. And it also plays an important role in contraction of muscle. calcium. So important in the movement of electricity and the contraction of muscle. Our number one intracellular ion, anyone have any remembrance? Is potassium. And I remember this because it's kind of shaped like an OK. And that, I guarantee you, this is one of those testable questions that will follow you throughout your entire EMS career. What's the number one intracellular ion inside the cell? Potassium. Potassium is expressed with a K. Why? I don't know. I didn't make it up, right? But that's how it's expressed. It's with a K. Potassium. You would think it would be a big P or something. It's a positive cation. And so it's a positive ion. And you can see it's got a little plus mark saying positive. What's the number one extracellular or outside of the cell ion? Any guesses? That's sodium. And I'm going to draw 4-to-1, but honestly, it all depends on what book you're reading. That's for the ratio of potassium and sodium. So the number one extracellular ion is sodium. The number one intracellular ion is potassium.
And what's sodium again?
The number one extracellular ion. So it's outside the extracellular. So if you hear intravascular versus extravascular, intravascular means it's in the pipes, extravascular means it's fluid outside the pipes. And I put 4-to-1 mix because it all depends on what book you're reading. Sometimes I have 8-to-1. So right now, if you look at all these positives, it is more positive outside of the cell than inside of the cell. So you got 1, 2, 3, 4, 5, 6 versus 1. So there's an electrical gradient between the two of them. And in this case, it's more negative inside the cell than outside of the cell. Or you can say it's more positive outside the cell than inside. So on this is called resting membrane potential. So resting membrane potential. And on our electrical, there's this, you'll see a chart probably, I think it's in this course, that will look something like this. It's going to have close enough to straight. Voltage, we'll say this is 0, and this is minus 100, and this is plus 100. So 0 means there's no charge at all. There's no difference between the outside and inside of the cell. Plus 100 means it's more positive inside the cell than outside, because that's what we're measuring. And right now, do you think it's more negative inside the cell than outside? It is, yep. So right now, our current resting membrane potential for this patient, for most people, is somewhere around minus 70. So this is a millivolts. So maybe let me write that one. MV per millivolts. And most people are riding around somewhere about minus 70. So this is the cell at rest, resting membrane potential. Nothing's happening at all electrically. And because of this, that's why we work asystole. Everyone knows what asystole is, right? So that's just this on the cardiac monitor, a big flat line. Nothing's happening. The reason why we work asystole is because there's potential. There's potential to move those ions. Everybody's cool with that? Okay. So the first thing that happens in this whole shebang for moving these ions is we have channels that open. So I'm going to draw some channels right here. And these channels are kind of like gateways. I have a white. Yeah, that's fancy. So there's these channels. And it's an interesting thing that happens here is when the cell is at rest, the resting membrane potential, it actually signals the cell that it's time to open some channels. So just the fact that the cell's at rest, it tells the cell we need to open some channels because there's an electrical gradient. And if you think about anything like even from thermodynamics to what's it called? Air freshener, right? Things want to go from high concentration to low concentration. Things that are hot want to cool off. Things that are really cold, what they want to warm up, right? So everything wants to change its state to even out. And because it's more negative inside the cell than outside the cell, it actually wants to change the gradient. So the first thing that happens is slow sodium channels start to open. And these are actually referred to as funny channels, which I think is kind of cute. So these funny channels will open and sodium starts to, sodium will start to leak into the cell. And as this sodium leaks into the cell, what do you think's happening in the cell? Is it becoming more positive? Absolutely. So over here on our action potential, you'll actually start to see this line start to creep up because it's becoming more positive inside itself. So a little bit more sodium leaks into the cell. And I told you those are called funny channels, right? Yeah, so cute. So a little bit more leaks into the cell. Well, unbeknownst to you, the person or whoever else, there's this imaginary threshold. And whenever we hit this threshold, it actually signals the cell to open more channels. So as soon as we become more positive inside of the cell than outside of the cell, we've reached this threshold and it keys the cell to open voltage gated channels, which is a fancy word for just when it reaches a certain voltage, it says open those gates. That makes sense? So these are slow sodium channels. As soon as we hit the threshold, bam, it tells the cell to open the fast sodium channel. And the sodium all of a sudden rushes into the cell. And as the sodium rushes into the cell, you're going to see over here on action potential that it just gets as positive as it can get. The sodium is rushing into the cell. Now it's way more positive inside of the cell than outside of the cell, and it's going to get rid of this potassium. So the potassium leaves. It has its own potassium channel. So let's draw this potassium leaving. And that's what we're becoming as positive we can get. You'll also see some calcium channels open up. And the calcium is going to squirt into that cell too.
This is after the sodium gets in, right?
Yeah, so what happens is when you reach the threshold, it opens voltage gated channels.
All the doors are.
Yeah, they're going to let all the sodium rush in to these fast sodium channels, and there's some other mechanisms that are extremely complicated. There's a little a capsule in here that has more calcium in it to release, but some's going to come through that membrane. But I don't want to get super complicated in this. I just want you to see now this cell is as positive. So all the fast sodium rushes in, some of that calcium rushes in, and it's just as positive as it can get. So all of the ions are now inside of that cell. The potassium is outside of the cell. And the cell has, in essence, fired off the 10 pulse. If this is the cardiac cell, This is the cell that maybe is up in the SA node and fires off and creates the pacemaker of the heart. Or if it's a cell in my arm where my brain tells my mouth to move and all these muscles work, right? So this is happening trillions of times a second all over your body. So now that the cell has fired off, that's called depolarization. Depolarization. Why are you clicking? You and the clicking. You gotta get you a quieter mouse. So that's when it fires off. It fires off. Fires off. Some people say that. It depolarizes. The cell is as positive as it can get. That tells the cell, I have to repolarize, I have to reset and do it again. I have to be ready for the next time Hurley talks, or the next time he uses his fingers, or the next time we need to send an impulse down the heart. Doesn't matter. So the cell has to reset itself. Well, even though all of these sodium ions have gone into the cell and the potassium has left the cell, you have to remember overall in the environment, there's still more sodium outside of the cell than inside of the cell. Those are the only 4 sodium ions, right, that were available. So having said that, they do not want to go back from low pressure to high pressure. And there's still more potassium inside of the cells than outside, so the potassium doesn't want to go home either. They're happy that they're free. So it can't do it by itself. It needs a substance called adenosine triphosphate. And you'll see that expressed in the ATP. Adenosine triphosphate is the sodium potassium pump. So sometimes you're going to see NA pump. And it is going to reset the cell, which is called repolarization. Adenosine triphosphate is only created, will only be created if you're alive. So first off, we have to have some metabolism going on. We break down sugar into ATP. If for some, and it helps if you have oxygen, that's aerobic metabolism, right? So we do pretty good with aerobic metabolism, making ATP, because we have trillions of cells we have to repolarize, right? Let's say the person is not breathing and they switch to anaerobic metabolism, right? So our patient, for whatever reason, they're laying on the ground, they're not breathing, there's no oxygen going in and out, but their heart's still pumping. You could see this with patients who are in overdose. So narcotics, opioid overdose, right? It depresses the respiratory system, they become hypoxic, and it requires us to bag the patient. Well, they're still going to make ATP while they're in that state, while they're waiting on, someone to call 911, first responders to show up back, but they make less ATP. And you're not going to make enough ATP to sustain life. So I like to think of ATP as kind of like a coffee mug. Here's my coffee mug, and it's full of coffee. Do we have brown? This is close enough. Orange. So whatever that is. Yeah, there you go. Vanilla latte. So normally, our normal metabolism is you use a little bit of ATP, but we're making more than we're using because we have metabolism and things happen. But let's say that person's laying in their car, they're cyanotic, they're not breathing, they got a heart rate of 60. Eventually, they're pouring out ATP without replacing it, and they die. They die because they can no longer produce ATP. And so they'll go from heart rate like 60, and then eventually it'll slow down and widen out, and they get into one of these, and then they die. They die forever, right? And you're not going to bring them back because we don't have ATP to inject into their body to enable the cells to repolarize. Right, so ATP kicks in. And it just reverses these arrows basically. Go 2 fingers at least.
Marley,
Yes.
do you mind if she hangs out for a second? This is her favorite topic.
No, come on in.
You're-
Absolutely. Make yourself at home.
I just.
Yeah, that's no problem. We just went over, resting membrane potential depolarization, we're talking about ATP. Yeah. So ATP is now going to pump the sodium back out, because remember, it doesn't want to go from low concentration to high, it wants to go from high to low. Like everything does, right? So here's our sodium being pumped out. And as it's being pumped out, we are also going to return the potassium to its home. Go back home, potassium. This calcium, there's actually a little collection of calcium inside the cell, but just so you can kind of visualize the calcium. And now we have repolarized the cell. What do you think happens to our action potential? It's coming right back on down. As we're pumping out the sodium and pumping back the potassium, and we return to our baseline. So this is a cell that is polarized. You have slow sodium channels that open, and those are called funny channels. These are slow sodium channels. This zone here. Then you have fast sodium channel. You're going to get a little bit of that calcium squirted in this zone up here. And then ATP kicks in. And it returns the sodium back to where it's supposed to go. It returns the potassium back to where it's supposed to go. And it resets the cell. So as the thing kind of returns back down to its baseline. And these are expressed, and on the book you read, this might be phase 0, 1, 2, 3, and 4, or you might see A, B, C, or D. It doesn't matter as long as you understand what's going on here. Polarized, slow sodium channels, fast sodium channels, calcium squirts in there, and then your ATP kicks in for repolarization, and it's returning back to its baseline. Just the act of returning to its baseline then keys the channel to open what, or the cell to open what channels. When you're in resting membrane potential, just having that electrical gradient difference tells the cell to open which channel. Which one's open first? Slow ones or the fast ones? Slow, walk before you run, right? So, and those are called what kind of channels? They're funny channels. Yeah, because it's a weird thing, right? We call them funny channels. All right, so understanding this can tell you almost what a lot of our medications do. So if you can understand slow sodium channels, fast sodium channels, calcium channels, what's the important role of calcium? What's it do?
Oh,
It holds, it bathes and keeps the cell membrane together, right? And it plays an important role with the movement of electricity across the membrane and the contraction of muscles. All right, so let me give you a few examples of things that happen that you're going to see that you maybe you've already seen but didn't realize it. Has anyone ever had a dialysis patient on their trip? Yeah. Those happen a lot around here, right? All right, so is anyone here familiar with some of the things that dialysis patients they kind of keep track of as far as their labs and things? Well, I'll tell you what, before I don't want to give away the answer until I kind of explain some things. Have you ever had a patient that is in hyperkalemia? Have you ever heard of that phrase before?
Yes.
What does hyperkalemia mean? High potassium. Now, is it high potassium inside of the cell or outside of the cell? Actually, it's outside of the cell. When they stick, when they stick that needle right to pull labs, where do they put the needle? They stick it in the vein, right? And then they draw the usually vacuum chambers, vacuum tubes. They connect it to it. It fills full of blood. They run it to the lab. they can't check what's inside of the cell. So what they're looking for is free potassium. So I'm just gonna draw a bunch of potassium outside of the cell. So when they do their labs, depending on what book you read, it's usually 4 to 6. I'm gonna throw that number out there. It doesn't mean that's right, because it really depends on what book you're reading. You might see 3 to 5, you might see 4.5, 6.5, but 4 to 6 is probably a good middle of the road when we start talking about labs for potassium. Anything less than 4 would be hypokalemia. Anything greater than 6 would be hyperkalemia. So just think about it when they stick the needle in the old vein here and they draw that blood up, they're checking for free potassium. So if you have too much potassium, what part of this action potential do you think it's going to affect? That's why I did the collars over there.
The channel?
If you have too much potassium, right? What do you think it will affect on this action potential? Anything to do with the cell firing off? Because it's the firing off side, right? Or it'd be with the repolarization side. Yeah, because this is where your potassium channels are, right? Correct? All right. And that's exactly what you're going to see with these dialysis patients that are in hyperkalemia. They're going to have a hard time repolarizing. And I know that you don't know this yet, but that's why we're here to learn. In our EKG findings, you're going to have a waveform that looks like this. This little P wave is the top of the heart, the atrial firing off. This QRS is the ventricle firing off, and the T wave is the ventricle repolarizing. If you have a problem, the normal T wave should look about like this. It's about half the size of your QRS complex. So if you see a problem with this T wave being all really big, it's a problem with repolarization, and it can be due to too much potassium. It's harder to repolarize the cell because of all this potassium it has to deal with. Well, another symptom that you're going to find with your patient is weakness. So potassium, it slows down muscle function. These big muscle groups like your legs, it slows down the ability to use those muscles. Because think about how much potassium you can have in this muscle versus this muscle, heart muscle. Right? So if you get too much potassium, common sign of symptom is just malaise, weakness. Great example that I ran into, we had a 60-year-old male patient, and they called 911 for weakness. We show up on scene as myself with Dan Thomas. He's an excellent EMT over in Sumter, and he's a firefighter by me in advanced hour. So we get there, there's a guy with a great attitude laying on the floor, and a big smile on his face. He goes, "I'm just too weak to stay." I said, "Well, Mr. Murley, we're going to take great care of you. No problem." So he's on like 100 pounds. We scooped him up on the stretcher. And, you know, I do my primary assessment. I do my AFPU. He's alert during ×4. That's great. ABCs, he's breathing just fine. And I didn't check his blood pressure. His skin looks good though. I didn't check pulse. So I said, okay, well, air's going in and out. Apparently blood's going around and around because he's getting blood to his brain with oxygen, right? He's talking to me. And his skin looks good. This is going to be an easy call for Dan to run. We get him in the truck. I said, let me know if you need anything. We're only a few blocks from here. Over off of Brooklyn, some goat trail over there. So I get in the front. I said, let me know when you're ready. And usually they'll check like baseline vital signs before we go. So I'm sitting there and I hear. He goes, "Hey, I think I might need you back here." I said, "Man, come on. You can't even check our blood pressure." So I'm coming to save the day. So I get in the back of the ambulance. And I did the exact same thing. What in the world? Tick. And this time I just barely let the air out. And as that dial was coming down really slow, when it got to 50, it went just like a weird long squish. I said, "Give me the cardiac monitor leads." So we put him on the cardiac monitor, and this is what I saw. So he had a rhythm that looked like this. And the rate said 12 to 20. It would show 12, and then it would show 20. I said, "Oh my God, are you okay?" The guy said, "I'm just too weak to stand." Now all of a sudden, I'm having chest pain, short of breath. I'm going through my brainy algorithm that's at the doc eating ice cream back then, atropine, TCP, dopamine, was isoproterenol, or epi than isoproterenol. They took the ice cream away from us. So I said, so his heart rate was super low. I can't get a blood pressure on. And what's the first thing I do is I try to get a line, right? Because I'm gonna do atropine. And so they taught me in paramedic school, the brand new paramedic, stick it with whatever will hold. And this dude had little thin arms, but he had one giant vein the size of my finger. So I grabbed a 14 gauge gel coat, which is huge, right? And I stuck it and it just went flattened down. I blew it. So I was like, oh crap. So I can't get an IV. I'm sweating bullets. I put the pacing pads on him, the defib pads. And you always set the rate at 70 and you start low and you run the millivolts up to you temperature. So when you get to about 80, they're not going to tolerate it much more than that. And this poor guy, he was going like this. He was twitching every time that electricity would hit him, and I can't capture it. He's like, please stop doing that, right? So I'm like, I'm so sorry. I'm trying to save your life. And so I'm like my brain is just like short circuiting. And I go, Dan, where the hell are we? He goes, we're only 2 blocks from Toomey. I was like, you drive me to the hospital, go through it. So he gets out. As we're pulling into the ER, EJing. Have you ever seen that? So this poor guy, I got his head pushed over the side, I'm sticking a big old needle in his neck. I get the EJ, I couldn't believe it. And so I just capped it off because we're at the hospital. We go to the room. Dr. Alexander, I don't know if you have anyone who remembers him, he's dead now, rest his soul, he was a jerk. He comes in the room, I give him a quick, story. And he says, okay, they tried pacing the patient. They can't capture. He gives 0.5 or 1 milligrams of atropine to the EJ. It doesn't work. Dr. Clank walks up while this is happening. And Clank goes, well, what's going on? I said, I don't know, man, you tell me. So I showed him the EKG and he goes, hyperkalemia. He goes, hold on, check this out. He walks in the room, he orders D50 and insulin. And as soon as they push it, that dude's rate does this right here. This is magic. And the rate was like 100 or something. I was like, what in the world is going on here? He goes, do me a favor, write a 4-page, here's my neck control. I want you to write a 4-page essay on hyperkalemia and bring it back to me. So whatever, by the end of the week. Crap, I just got homework assignment getting to my neck control. And he literally said this, I'll never forget it. I hope you guys invite him over to teach. He goes, you could have been the Adonis. I said, what? He goes, you could have been the Adonis today, but you failed. I said, damn, that hurts. I don't even know who Adonis is. It's like, God. So here's what I learned about that paper, and this is why I want to do action. This patient was in hyperkalemia. Hyperkalemia slows down everything, right? It slows down the muscle function of your legs, of your arms, of your heart, and it delays repolarization. It slows everything down because it delays repolarization. Matter of fact, potassium is one of the medications they push with lethal injections. So they'll sedate the patient and they give them just a massive dose of potassium because it puts them into a system.
So you're telling me if I eat a bunch of bananas?
No, you will not be able to do that. You can try. You're trying to poop in your brain now. But so.
Bananas, you know what I'm saying?
But so check this out. I don't know how to save this. That didn't work. Is there a way to screen out? Oh, look at my fingers. Okay. That looks like fuzzy, you know what? So that's okay. So here's what I learned when I did my potassium paper is that these renal failure patients, they usually don't start with hyperkalemia. They start with something called hypocalcemia. So I'm gonna erase all this real quick. Tracy, what are you talking about back there? Come on, man. We got a guest in the class. At least act like. Are you talking about this?
Yeah.
Well, share it with me. What are you talking?
I looked over at Angel's handwriting, I was like, tell me how good her handwriting was.
With my note, I was taking some notes.
Yeah, I took a picture of it. I can't write.
Took
that
a
good.
picture of her notes.
No, of like the computer screen, cause
Oh.
my handwriting is garbage.
All right. All right, so let's talk about this. Hypocalcemia. Just from the name, you figure out that the calcium levels are low. So, and you remember, I love turbo dose, you said it. Calcium plays an important role in what?
Membrane,
Yeah. So it plays an important role in keeping the cell membrane together. So if we take away the calcium, what do you think happens to the cell membrane? It starts to break down. And you're no longer able to sequester the potassium because there are high concentrations of potassium in the cell, but low concentrations outside the cell. So the potassium wants to leave, but now it doesn't have to go through a gate. It can just leak on out of the cell. And this has happened in not just one little tiny cell. This has happened in a global area, right? So now you have way too much potassium outside of the cell. And there are signs that we can see on the cardiac monitor of hypocalcemia. It's usually really small levels on your EKG machine, right? On your 3-lead, you'll see tiny little waveforms because it plays an important role in the movement of electricity. So if you have really small, like if this is your normal P, Q, or ST, you might have ones that look like this. Have you ever seen that on a patient? Like put them on the cardiac monitor, like, it's what? These things are really small. Have you ever noticed that? Patient could be having hypocalcemia. Hypocalcemia is usually a precursor to hyperkalemia. Right? So how can you fix hypocalcemia? We carry calcium gluconate, and calcium chloride. Yep, that's one thing. We could try to push that calcium, and guess what it does? It bathes the cell membrane. It makes it whole, and it's able to sequester that potassium. So that's one way to do it. Well, with my guy, which if I would have known what I was even looking at, do you have any idea of how I could handle that as a paramedic? I don't carry insulin, right? So like the insulin is the key to the cell. When you open the cell up, the potassium will go home. They give D50 before the insulin because they're going to raise those glucose levels up higher, right? Which happens with a little bit of ATP. And then they're going to open it up with the insulin. But we don't carry insulin, so we can't give that in the field. So what medications could I give to help this patient out? We just mentioned one of them. Calcium. The first one I'm going to give is calcium. And it's an effort to fix the cell membrane. I'm going to push that and I'm going to try to make the cell membrane whole again. Fix these holes. And that shuts down these extra pathways for this potassium just to leak out on me. Fix that.
So my question is, at the advanced level, that is the paramedic field, right?
Well, these drugs are,
Yeah.
but
These
it's an important thing for you to understand because you're going to have to do an assessment and determine whether this is something you can handle or someone else has to handle. And even if you're working a cardiac arrest, because you will be working cardiac arrest, and you're going to call for what? ALS backup? Or you're going to take them, to the nearest ER or whatever. But you've got to be able to express to somebody that you believe this is the problem, right? The correct path of care. Because if not, when they show up, like let's say I arrive on scene and I have a basic crew or an advanced crew working cardiac arrest, I have to start from the beginning of my algorithm, right? I'm going to push epi. I'm going to circulate for 3 to 5 minutes because you can push every 3 to 5 minutes. If they're in PEA very simply, probably PEA in this patient, then I'm going to start considering my H's and my P's. So in that process, hopefully I can do it quickly, which now that I've been doing it for 20 plus years, I'll get to it pretty fast. But it could take someone that has been doing it for a long time say 5 or less years, it could take them 15 minutes to figure out, oh, maybe we should try some of these medications. Well, 10 or 15 minutes later, you're not gonna get them back. So you have to be able to figure out quick. So calcium would be my first drug of choice to fix the cell membrane. Green in here. And then we can push a drug called sodium bicarbonate. The bicarb will cause a fluid shift. It will cause the potassium to go home. And guess what happens to that? First thing first, the calcium will speed this up, right? Because it plays an important role in the movement of electricity. And it actually plays an important role in the contraction of muscle. So if I had that young man, or 50 or 60-year-old laying on the floor, if I would have just thought to give him some calcium, it would have improved this scene greatly, right? It would have helped things out a lot. It would have sped up that rhythm from greater than 12 to 20. And hopefully it would shut down all these pathways that's allowing the potassium to leak out, and then they could start processing it again. Right? And then if I had to, I could try sodium bicarb, and the bicarb would force it back. What you'll see a lot in cardiac arrest, especially with dialysis patients. Has anyone ever seen dialysis patients? They resuscitate. So what will usually happen is this is the kind of common pathway for paramedics. They go to the dialysis center, and the patient's in a PEA type rhythm. They'll push epi, and they'll get them in the truck. They'll push another epi, and then they'll say, well, they may deal with the airway, right? Well, let's go ahead and intubate them. So they'll take a minute or two to intubate the patient, and then hopefully put them on the capnography and all that, and so monitor the CPR quality. And then they'll say, well, let's consider our H's and our T's. And one of the, do you guys know what I mean when I say H's and T's? These are just common reversible causes. I apologize. You have H's. And T's. And these stand for common causes of pulseless electrical activity. They're called reversible causes. One of them is hypoxia. How would we fix hypoxia? You BVM them, right? And you're going to say, okay, that's one of my H's. What about hypovolemia? That means low volume. We're going to give them a fluid challenge. We usually give them saline, normal saline. Guess what comes in normal saline? What's inside of there is salt. So we usually give them some salt, water, or sometimes people call it cold pasta water, what it is. What about hypoglycemia? So I put this in here, even though AHA is taking it out, in a low flow state, which means like they're in cardiac arrest and we're flowing for them, right? Your sugar, your finger stick is not going to be accurate. So, but let's say your patient isn't in a low flow state, and you have some type of like say ultramilli status. It's something that that you should rule out. So I leave it in there for me, but it's not in the current AHA guidelines. Okay, what about hydrogen ion? That's a good one. I'm glad I didn't think about it till now. Let's talk about hydrogen ion real quick as we're working our way to this potassium level. So when a patient becomes acidotic, they become hyperkalemic. And so I'm going to erase this, but we'll come back to the H's and T's. That's why I like doing this like loose, because things will come up. So whenever someone produces acid, which we're going to do our acid-base balance like ABG stuff in a little bit, you end up with an extra hydrogen ion. And the hydrogen ion, let me redraw all this stuff again. What's our number one extracellular ion?
Extracellular sodium.
That's right. So let's put the sodium back out here like it's supposed to be. Don't be yawning on me.
Oh, no.
Golly, these firefighters, man. So we'll do purple for the hydrogen ion. So whenever we produce waste in the body, it's hydrogen. Hydrogen is then bound with bicarbonate, which is produced by the kidneys. And when it binds to it, it creates one of two things. It's either going to be liquid that you pee out, or you're going to breathe it out as CO2, carbon. So that's how we get rid of acid. We pee it out or we blow it off. So that's a buffering system. One works faster than the other one. If I start breathing really fast, what do you think I'm doing to my CO2 levels? Am I blowing it off or am I retaining it? I'm blowing it off. So I'm dropping my CO2 levels, which means I'm blowing off more acid. And if I do that for a long period of time, I actually get cramps on my fingers, and I'll get dizzy, and I'll stop breathing, right? Because we're blowing off too much carbon. And what happens is I will eventually lay flat on the ground and stop breathing for a short period of time. And then I'll start breathing normal again as the acid level builds up, because you have to know that in your medulla oblongata, it should be in your basic class, but maybe it wasn't, it's okay. Your medulla oblongata is your computer that tells you when to breathe. And it's always sampling the amount of carbon that's in the blood, the acid level. So we have a carbonic drive that's ran in the computer there in the brain, or midbrain. If you blow off too much carbon, it says, well, you don't need to breathe anymore because the carbon levels are really low. And that's why people who hyperventilate will eventually just pass out and they stop breathing, which is fine. And it allows for the carbon level to come up, and then the computer says, okay, now we can breathe normal. Okay, when we have too much acid, though, it creates this hydrogen ion. I'm going to draw it as an H with a plus, this positive. And now we're messing with the electrical gradient outside of the cell. It's too positive outside of the cell. And what the cell does, what it does is, well, we have to neutralize some of this out, and the hydrogen ion will actually enter the cell. And now the cell goes, oh crap, we're too positive inside of the cell. I've got to get rid of something. Well, there's more potassium in the cell, but it'll kick it out to here. So it's like, potassium, you got to go. And now this whole cell has become acidotic. This happens on more and more cells. It kicks out more and more potassium, and now we're in hyperkalemia, right? So this is another form of hyperkalemia. So how would we fix this? How do we, what binds to the hydrogen ion to create urine or CO2 you breathe off? It's produced by the kidneys, bicarbonate. So I could push some sodium bicarbonate. The bicarb will start binding to these. It basically just literally binds to it and creates something else. And all this hydrogen stuff goes away. And what happens to the potassium? It says, oh, when ATP kicks in, I can go home now. The ATP will now pump the potassium back into the cell. So acidosis can cause hyperkalemia. So in that patient that I had, I would fix the calcium first, right? And then see if that fixes everything. I'm going to give ATP its opportunity to do its job and return the potassium home. And if that don't work, then I'm going to get some sodium bicarbonate, because the bicarbonate, well, maybe there's too much hydrogen. Maybe it slowed his breathing down too much, right? He's acidotic. So he's in a metabolic acidosis. So I give the bicarb to bind with the hydrogen, and it allows the potassium to go home. Is that amazing or what? Am I blowing your brains up here?
Well,
Well, okay, have I lost you on anything yet?
Not yet.
Listen, I want to take I want to take lunch in like 30 minutes. So can we just push through? We should be able to break right now. Can we just push through for a little bit longer? Okay.
Go ahead, salt pedal. Let's do it.
What, if anything that I said doesn't make any sense at all? This clicks a lot. Well, change your name. Nikki clicks a lot. You understand the number one extracellular ion, the number one I'm sorry, intracellular ion. The number one, extracellular sodium, and calcium plays an important role in keeping the cell membrane together, movement of electricity across the membrane, and the contraction of muscle, right? You got that down.
Oh, yeah.
You understand what happens when the slow sodium channel is open and then the fast one's open, depolarizes. And then you get a little bit of calcium in there and then it repolarizes. You got that right. And hopefully, which it might be confusing, but I want to make, this is a video, so I'm going to post it for you. You saw where when you lose calcium, they become hypocalcemic. You lose the cell membrane and the potassium leaks out, causing hyperkalemia, right? So you understand that hypocalcemia leads to hyperkalemia. We understand that, right? Because that's everything we just went over. And then we also went over that if you have a buildup of acid in the body, it creates a hydrogen ion. That hydrogen ion throws off the electrical gradient and it causes the potassium to be kicked out of the cell. And therefore causes hyperkalemia. So that's where we would use the sodium bicarbonate, right, to effectively bind to that hydrogen ion, and then they're going to pee it off or they're going to blow it out. So those are important things to know also. So if they're going to pee it off, then they probably need to have a tube sticking in there, right? So they can get rid of it, right? So they're going to get some type of a Foley cap. It's going to go to a bag. And we probably need to have it intubated because then we can actually help blow that off. Okay, let me just cover some other drugs that you might not push, but I want you to just understand how they work. Have you ever heard of lidocaine? Okay. Do you know what lidocaine is? Okay, it's a weird question. It's an antidysrhythmic medication. We usually push it during VFib, VTAC when they're refractory to shocking. We'll give them a dose of lidocaine. And when we would use lidocaine is usually when you have the heart doing this, right? It's going crazy. But VFib will shock them, doesn't help. So during VFib, VTAC, the heart muscle, all these things are firing off. Instead of 60 to 100 times a minute, it's firing off 600, 1200 times a minute. The whole thing's quivering, right? We want to slow that down and allow the top of the heart to take over its normal job of pacing the heart, which we're going to cover more of that in cardiology, but I just want to give you an introduction. I'm planting seeds right now. Johnny Appleseed up here. So what you do with lidocaine is it is a antidysrhythmic, but it's an antidysrhythmic because it blocks fast sodium channels. So when I push lidocaine, I'm effectively blocking the depolarization phase. So it's a weight-based drug. So we'll take the patient's weight. You know, we're all like circus performers where they guessing people's weight. How good do you think paramedics are really guessing people's weight? We're not very good at it, but we're going to make a guess on your weight. And then we're going to push the drug. And what we're hoping happens, we're hoping that it doesn't allow the cell to fire off. So we'll say this is the action potential. We hope that we push it enough to where it goes right back down and just returns down to its baseline because it was not allowed to fire off. So this would generally be one of the things. I'm just drawing the heart here. I'm going to draw the 4 chambers of the heart. Everybody's got that right. These are the ventricles down here. Usually the cause of this VFib and VTAC is irritability. So you'll have some cells down here that aren't getting good blood supply. And they're irritable and they start firing off impulses. And if it happens at the wrong time in that conduction cycle, it can take over the heart and the VTAC, which can quickly dissolve into VFib. So when we push the lidocaine, we're hoping these are what I would consider sick cells. So these cells right here are hypoxic and irritable. I want to make them even sicker. So when I push the lidocaine, I'm in essence going to make it to where these cells can no longer fire off. And if they don't fire off, then that's going to allow the top of the heart, the SSA node, to fire off. And that will return them to a normal rhythm. So it slows down the depolarization phase. So what do you think that would happen if I gave them too much lidocaine?
It might stop the heart.
Exactly, and what do you think that the EKG would look like?
What?
Yeah, absolutely, see? Yep, you're absolutely right. If you give them too much lidocaine, you're gonna put them in asystole, yeah. So I'm just gonna draw this up here. Like this. This is too much lidocaine. And there was actually a paramedic that worked Richmond County EMS a long time ago that killed himself, committed suicide with lidocaine. He took a bunch of lidocaine home with him. He created his own grip of lidocaine and just wrote a suicide note, ran it wide open. So that will cause seizures and it will cause asystole. So do you remember that? I don't know if you remember that happened. It's a while back. So that's an example of lidocaine. It tries to prevent the sick cell from firing off. Do you know another anti-disrhythmic medication, Gary? Amiodarone. Have you heard of that one?
Yeah.
Yeah.
That's kind of the newest one on the block, right?
Matter of fact, we would have waited a lot of things.
Yeah. That's what the Air Force has done too. They don't vary anymore. So amiodarone blocks the reuptake of potassium. Now, it also blocks some sodium channels, but the predominance of its effect is on the potassium channels over here. So maybe I should have drawn that for the. I'll draw this for the fast sodium channel blockers. The lidocaine blocks these. And over here, potassium, it blocks a little bit of this, but really the majority of its lifting comes over here in potassium. It's a potassium channel blocker. So the interesting thing about potassium or the amiodarone, it allows the cell to fire off, but it slows down the repolarization phase. So the same thing happens here with the when the patient's in defib. All of these little things are firing off the impulse. Well, it actually just slows them down. Hopefully it slows it down enough to where it can start pacing, the heart can return to its normal cycle. So where lidocaine blocks the cell from firing off, the amiodarone slows down repolarization. It lengthens the time from this P to the Q here, slows down the whole cycle. Yeah, slows down the repolarization phase. All right, and trying to think of something else. What about if you want to slow? What's another way to slow down fast heart rates? Like I said, this won't be in your scope. But you need to have an understanding of this active potential and how it works. What's another channel we haven't blocked yet? Calcium channel blocker. So, have you ever heard of a calcium channel blocker?
What kind of channel block I've heard was on the TV?
Yeah, that's all right. So, Clarendon Fire Rescue carries a calcium channel blocker. So, trying to remember which one they carry, but I think it's Cardizem.
It is. I was kidding.
Yeah.
I gotta know my.
Cardizem is a calcium channel blocker. So, Cardizem. I'm just going to try to reset some of this. Blocks these calcium channels in an effort to slow down the rate. So let's say you have a patient who has a tachydysrhythmia and you need to slow it down. One of the ones you can push is the calcium channel blocker. And it doesn't allow the cell to fire off as forcefully as it used to. And so it slows down the movement of electricity across the membrane, which slows down the heart rate. And what's the other thing calcium does? Force a contraction. So it doesn't allow the heart to contract as hard as it used to. And you need to understand that cardiac output, that's a bad color for it. Let's do red. Cardiac, oh, let's do thicker, come on. Cardiac output equals heart rate times stroke volume. So if we want to change cardiac output, then we either need to slow down the heart rate or reduce the stroke volume. So calcium channel blockers do a great job of both of those things, right? It hits the equation on both sides. It will slow down heart rate because it slows down the movement of electricity across the membrane. And it slows down the force of contraction, which reduces stroke volume. So you're hitting it on both sides. You got it? Is it making sense? So all the drugs that they're carrying anyway, all we're doing is affecting different receptor sites on the cell. And we're either blocking it or we're allowing it to happen. So there's no drug that they push that changes the body's normal metabolism or the normal function of the cell. You're either blocking it or you're enhancing it. Questions? There's got to be some questions. I know Tracy don't understand anything. He just went over. Tracy, what's your question? Come on, don't be shy. I know you're not shy.
Well, I'm not sure, man, I'm just,
I think it's just a lot of information that's gonna take a few minutes.
it's gonna take me, if you give me about another 5 minutes, I'll have a question.
I'm gonna give you all the time you want, man.
All right. I'm always saying I wasn't fast enough. I'm gonna be dumb, man, I know what love is.
The
I love it.
and you know, Tracy's got a good point. A lot of these meds are going to be outside your scope of practice, but the thing is, you're going to be tested on the knowledge of all these things. You got to understand action potential. You got to understand the potassium, the sodium and potassium channels. You got to understand the hydrogen ion and how that causes the hyperkalemia. I didn't go over the rest of the H's and the T's. Some of the T's are, well, I think there was one more H.
Yeah. One more.
These T's over here.
One of the major problems, Bill.
Help, I need somebody to get it going on in this party. Help. So we went over like hypoxia, hypervolemia or hypovolemia, I mean, the hydrogen ion, hypoglycemia. I said it's not in the current AHA guidelines. If you have a patient in a low flow state, which means that their blood pressure is really low, then it's not going to be accurate. So we need to resuscitate that patient with fluid if we want to get an accurate VGO. So what's another H? I'm trying to think off the top of my head. That's hypovolemia.
I wouldn't wrote up there again, I thought it was okay.
Maybe let's think of some of the T's, trauma. Tension pneumothorax, and you guys are going to learn a lot about pneumothoraxes. What's some more T's? Tamponade. And then thrombosis, which is a blockage. That's a blockage in a artery, which could be in the brain, it could be in the heart. What's the missing H? Hold on, let me Google. Speaking of strokes,
Yeah, dude, yeah. It's like a time.
Yeah.
I have to go to heart.
Yeah, ours has
Well, I
just
had
been like
two.
blowing.
We were having a hard time with our baby.
so hypovolemia, hypoxia, hydrogen ion. Oh, the one we were doing, darn it. Hypo and hyperkalemia, that's the missing H.
Wow.
It's the one we were doing.
So,
I know.
I have a question,
Yes,
hypophagia, if you normally, if you saw it, would you see you can do it with dialysis patients?
well, you can. So the problem you're going to get into is you have to be able to do an assessment of that patient and determine, is this a renal failure patient? So some of the easy things to find are shunts, right? Those big fistulas and shunts. So that's something you want to look at. So if you get a patient that's at home, unconscious, unresponsive, And it is within your scope to put them on a monitor and a 12-lead transmit. And that the reason we're going over this is because those are some things you're gonna see, like the slow, these slow rhythms like this. So that should be a clue, right? Maybe you'll see big T waves. You're gonna wonder what those are, or these slow rhythms. And that should be a clue, like maybe this is a renal failure patient. And you're gonna look for those dialysis fistulas and shunts, right? But it also could be a new onset renal failure patient. My best friend's mom died from renal failure. They didn't know she had renal failure. She got into renal failure. What are some things that cause renal failure? What's some things that keeps your kidneys from working properly?
Diabetes always goes.
Yeah, diabetes is an obstructive disorder.
Yeah.
So it's really blood flow to those kidneys.
You
So-
got filtration for problems in filtration.
Yeah. The purpose of those kidneys
Or the disease kidney.
is to filter out the blood, right? And it's going to remove waste, and it's a really big manager of salt. The more salt you have in the body, the higher your blood pressure is going to be because you retain salt. You have more circulating volume, which is part of this. Yeah. And what else? And also above the kidneys, which are renal, you have these adrenal glands that sit on top of, and they produce epinephrine, adrenaline, and they also produce bicarb. So they play an important role in the binding of those hydrogen ions and peeing it out because it's filtering it out or blowing it off. So everything is really super connected.
It's come together.
Is it really, or are you just saying that?
That's all it's all coming together.
I hope, well, I felt like up until today, you probably haven't learned anything. It should have all been on some. But then I wanted to start planting these seeds because as we move into these other chapters, we're gonna start going into these things, but they tend to brush over it. When I went through my paramedic class, you know what they told me about acid-base balance? It's not on the test. You know what they told me about ABGs?
Look, I ain't gonna lie, they said it ain't on the test, I'm like, thank you, baby Jesus.
It's not on the test, but what happened over early, right? Like week one of being a paramedic, you know, Al said your ticket is you're gonna respond to these patients that are laid on the floor going, I'm just too weak to stay. You know what I mean? Like, hey, baby, we'll take great care of it. And I'll tell you what, I was so lucky that I got there just before he was in cardiac arrest. Normally, you know, they lay on the floor and they get into this and they go into cardiac arrest. So we'll show them there in the slow PEA rhythm. And it might take, would have took me a long time to figure out, maybe 15 minutes. By the time I'm at the hospital, you know what I mean? And the odds of getting back are slim enough. So that guy there, that's what Dr. Clank did. You could have been being honest. I could have saved that dude's life. And I'm so lucky I didn't kill him. You know, delaying transport, sitting on scene, trying all these things that weren't going to work. The atropine wasn't going to work because of the hyperkalemia, the pacing. He wasn't going to capture with the pacing because of hyperkalemia. We had metabolic derangement that problems with the ions. And I'm telling you, in my class, they said, it's on the test. Boop, boop, you don't need it. But guess what? I needed it. Boop, 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 boop. I forgot. I was looking up some, and there's a lot more than just 4. There's a whole bunch of reversible causes, but a really good one to remember is toxins. So it could be one of your T's. And what would you do for toxins? It's most likely going to be like a opioid or something. Because, you know, opioids suppress everything. Your breathing, your heart rate, everything is down. So you could find someone like that. Try Narcan.
Narcan.
Yeah. And you can get Narcan.
Yeah.
You can get Narcan any kind of way you can give it. You can give it IV, you can give it IM. So if you don't have an IV, yeah, you can give it nasal. So if you had a patient that was, you know, severely, everything's depressed, their blood pressure's down, their heart rate's down, they just have no good veins, can't get a vein. Maybe they've been for IV drug use that kind of ruined everything.
But I mean, you can give Narcan ain't hurt them anyway.
Yeah. If you don't have the atomizer, just give it IM. Just give them an ml over here, an ml over here, one here, you know what I mean? Just like, so all these, yeah, all these big muscles and it'll work. What else? What else have you maybe seen in the past that didn't make sense, that had something to do with action potential? Yeah. Anything you think of? Was this helpful?
It is interesting to learn how the drug actually works, where it works.
Yeah.
You know, what happens.
If you give lidocaine, somebody will have a PVC.
Yeah. Yeah, so lidocaine is so let's talk about that. The number one cause of PVCs is irritability. We'll do that real quick and then we'll.
Got that angry cell down there.
Yeah, you're gonna have a cell that is not getting blood supply to it. And there's probably a way to do a screen wipe on this, but I'm not fixing it. So we'll say this is the heart. This would be the right ventricle, left ventricle, left atrium, right atrium. So the number one cause of, and then let's over the top of that, let's draw coronary arteries. So here's the aorta coming off the top of the heart. We have these semilunar valves that when the left ventricle pumps, it actually blasts open those semilunar valves. Those semilunar valves actually protect, this is the right coronary artery, RCA. So this is laid down over the top of the muscle there. And they actually branch off. They have these marginals that branch off. So this is an artery. It's supplying blood flow to the muscle below it. And then on the other side, you have the left coronary artery. It comes down like this. You have this anterior descending. And then you have a circumflex that goes around behind the heart. So the circumflex peels off and goes around back behind the heart. It disappears from our view, but it just keeps on. You have to just kind of picture it, keep on going that way.
It's not bad, bro.
Thank you. And then these also have these diagonals that come off this. So that ain't too bad. So not at all. So an interesting concept to realize is when the left ventricle pumps, it actually kicks these valves open. These actually flap open and they protect the coronary arteries. The coronary arteries are the only arteries in the body that perfuse while the heart is at rest. So what happens is all the other arteries is when the heart pumps, that blood flows up through the aorta all the way down to your hips, right? When those valves pop open, they protect the artery that's behind them. And then as soon as the pressure starts to equalize in the aorta, they slam shut. And then what happens is the blood backfills the coronary arteries. So they're the only arteries in the body that are perfused while the heart's at rest. So when it relaxes, the blood goes back through these arteries. So for that reason, the heart can only perfuse itself when it is resting. Isn't that weird? It's the only muscle in the body that happens. So, and that's the problem you get with these really high heart rates. If it gets up over 180, the heart isn't relaxing enough to actually perfuse itself. And it becomes irritable because it's not getting enough oxygen. That's one way it could happen. Another way is, let's say way down here off one of these diagonals, you have a little tiny infarction. So something has now blocked this coronary artery way down the line, right? Well, the zone around it, if you want to get like pinky out fancy, it's called a penumbra. I think it's kind of funny. Or most likely you'll see in the book like zone of ischemia. So that area of muscle around that spot is what's being perfused by that area. And now you have this zone that's ischemic, which means it's not getting oxygen, which means it's going to become irritable. And it's going to build up some lactic acid. It's not going to be able to get rid of the waste products. And when it becomes irritable, it starts to, let's draw it angry. Did it like that? There, bam. So now that site's irritable, it's gonna fire off an impulse because that's the only way it can get blood to come to it with oxygen is to fire off an impulse. So the number one cause of PVCs, which is called is irritability, or sorry, the number one cause of PVCs, which are called ectopic focus, and they look like this. Just a big old wide bizarre complex. The number one cause of that is irritability. And like you were saying, Candy, like one of the things we can do to take care of it is, well, so the trail goes like this. The number one cause of XP is irritability. The number one cause of irritability is hypoxia. So the first thing we do is stick them on nasal cannula. Regardless of what the finger probe says, I know AHA says it's 95 or greater, don't worry about it. But we're talking about the core, which can desat before the fingers. We'll put them on a little nasal cannula. And most of the time you'll see that knocks out XP, just a little bit more oxygen. But if that don't work, one of the things that we worry about are RONT PVC. So this is our P wave right here. If this PVC happens on the down slope of this T wave, it's called an RONT PVC. It'll look like this. Look like this right here. Boom. So if we see that, an RONT PVC, we're like, oh crap, that's malignant. Because what can happen is, instead of just throwing one PVC, they could do a run of VTAC. Yep. So they could all of a sudden look like this. And then you're gonna be like, oh my God, that's bad, right? That's VTAC. I have to do something about that. So of course, we're gonna put them on oxygen, and then we're gonna start thinking of an antidysarrhythmic. And I think Angel said they've gone away at lidocaine, which a lot of services have. So you're really stuck with amiodarone. So I'll give you one example, then we're going to do lunch because I run down the road back. So if I know that sodium or lidocaine is a sodium channel blocker and amiodarone is a potassium channel blocker, I'm going to give you an example of when I went to, not this last June, but June before last, and that was the old man running on the treadmill. Have I told you the story? Sweating bullets. So this old man's on a treadmill for an hour. There happens to be a firefighter and his wife, who's a nurse. They're watching him because he doesn't look good, like gray looking. And so they're like, this dude looks bad. So they're paying attention. And when he comes off the treadmill, and of course he's been pouring sweat the whole time. He looks a little wobbly, he sits on a bench and he just falls over in front of your eyes. He falls over. So the firefighter goes over and does what macho firefighters do. They do compression, good compression. And the wife calls 911 by getting an AED. So they run back over. Now I'm getting toned out for it at the gym. And they put the pads on him and it says shock advice, stand clear. They shock the patient. 2 minutes later, exactly, I walk in the door because I hear across the room saying, stand clear, analyzing rhythm, stand clear. Because I'm walking in the room, I'm like, shit, it is a cardiac arrest, because you never know, right? And so we're lowering the stretcher down, put the cardiac monitor off. It says, no shock advice, continue CPR. So while this is happening, I'm looking at the patient and I see him swallow. I said, hold on. So I checked, I said, this dude's got a pulse. So let's get him up on the stretcher real quick. So we just really grabbed him, threw him on the stretcher. He's breathing on his own, but he's completely unresponsive. When I went to do a sternum rub, his sternum's flailing. It's like sunk in and it's not stable. I was like, oh shit. Not good, whatever. Throw him on the monitor, sinus tach. He's not, I think he's moaning a little bit by now. And we're just getting him up and heading back to the truck. So on the walk back to the truck, I'm thinking, okay, well, he was in either VFib or VTAC because he was shocked by an AED. Because they tell me one shock, they tell me the story, they shocked him one time. So I'm thinking, well, I'm gonna give him an antidysrhythmic because that's what I would do if I walked up and shocked him. And if he converted, I would hang an antidysrhythmic because I don't want to go back in the VTAC, VFib, or whatever. Well, I have two choices at the time, lidocaine or amiodarone. So I'm thinking while I'm walking, well, if he was on a treadmill for an hour, how do you sweat? Do you know the process of sweating? What do you excrete? Yeah. That's all right. Sodium, because, well, the fluid follows salt. So in order to sweat, we push salt out. That's why you'll get like the sweat bands on your clothes and stuff. That's salt.
Taste it like.
Yeah, yeah. So I'm thinking as we're walking, I bet you money his salt levels are low because he's pushed it all out of his body during his workout. So, which post cardiac arrest, we normally hang a bag of normal saline, which has a bunch of salt in it, right? It's 0.9, 0.9%. And I know you don't know this yet, but a percent solution equals 0.9 grams per 100 ml. Which means we have 9 grams of salt in a 1,000 ml bag. So I know as a public drug, I'm gonna get him 9 grams of salt. I'm gonna get him back to it. So I'm thinking, you know what? I'm gonna hang Amiodarone because I want to stay away from the sodium channels. If he is challenged on his sodium levels, then I'm not gonna cause it to block him because he might not be able to depolarize. Does that make sense? Because sodium plays an important role in the depolarization of the cell. So I'm like, you know what? I'm gonna hang him. I'm gonna get 150/10. So we give him that, we get him in the truck. I give him the bag of salt water, right? Saline. And on the other arm, I start another IV and I hang a drip of Amiodarone. I give him 150 milligrams over 10 minutes. Haul ass to the hospital. We get to Toomey. We did a 12-liter course and it was Navy first thing. But we get to the hospital. And by that time now, like 1 block or 2 from Toomey, now he was on the right end, he started talking to me. And he said, he was asking, what happened? I said, you were on a treadmill for about an hour, you collapsed, you were in cardiac arrest. His chest was killing him. He's like, oh, my chest hurts really bad. So I said, a firefighter did chest compressions, I think you broke your sternum. I'm sorry. Yeah. And they shocked you, here we are. And as soon as I finished talking, he goes, what happened to you? I'd say, you were at the gym, you were on the treadmill, you collapsed in cardiac arrest. The firefighter did chest compressions. My chest is killing me. I think you broke your sternum. I'm sorry about that. The wife shocked you. Here we are. What happened to you? So when we get to almost where the post office is by Toomey, like 1 block away, I finished my story. He goes, I was on the treadmill. And I was like, hey, he's now processing information. Like things are getting great. And he's like, I think they broke my chest. I said, yeah, I think your chest is broke. Sorry, but I didn't want to get in pain meds because I just got his blood pressure up, you know what I mean? So I'm like, I'm not gonna do that. Get him to Toomey, they helicopter him to Columbia, and he goes to the cath lab. And guess what? His arteries are completely clean. But guess what his sodium was?
No.
It was 90. It should be 125 to 135. So the only thing wrong with this guy was he had low sodium. And the fancy word for that is hyponatremia. So the only thing wrong with this guy was he was on the treadmill, he pushed out too much salt, and hyponatremia can cause dysrhythmias, and that's what happened. So he starts having a dysrhythmia. He was probably in VTAC, and then that quickly dissolved into VTAC. And we showed up, they shocked him, we showed up, we didn't even shock him. And the only thing I gave that guy was sodium, which only brought it up to 90. And so I don't know how low it actually was. And then I gave him Amiodarone because I didn't want him to go back into this room. But I'm afraid if I would have hung lidocaine on that dude, probably would have killed him. Could have put him in a day system. So there is a time and a place for each drug, but most services are going the way of Amiodarone versus lidocaine.
See, that just confirmed my story, working out real quick.
Yeah, that's what.
Sure can.
All
All right, I'm going to pause this.